Our next speaker is Dr. Aimee Woods. Aimee completed her medical school training in University of Queensland in Brisbane, and she's done all of her O&G training here in Adelaide. She received her FRANSCOG in July and commenced MFM subspecialty training in August. She's interested in fetal diagnosis and therapies, including ultrasound and invasive procedures, for example, ultrasound diagnosis and counselling for fetal abnormalities, fetal interventions for complex twins, such as radiofrequency ablation and laser. Thank you.
Good evening. It's a pleasure to be able to talk to you all tonight on poor placentation and, whoops, go the right way, and the current evidence for therapies. I'm going to break this talk down into 3 parts. When placental invasion goes wrong, how we can identify the pregnancies at risk of complications from abnormal placentation, and if there is any evidence of therapies that may improve the outcomes. Professor Kong has introduced us to the process of early placental development and implantation, but what happens when implantation doesn't go correctly? Many complications of pregnancy have their origins in abnormal development of the placenta in the first trimester, including early onset preeclampsia, fetal growth restriction, unexplained stillbirth, placental abruption, and preterm labour. Term preeclampsia is a different beast, thought to be unrelated to abnormal placentation. Although it has a higher incidence, the disease burden and healthcare costs from term preeclampsia is a lot less significant than preterm preeclampsia. Placentas require a large amount of energy, consuming approximately 70% of the glucose and 40% of the oxygen that is normally supplied to the uterus in a regular physiological state. Therefore, in order to achieve optimal fetal growth and development, nutrient delivery to the uterus must exceed the placental demand, such that there are residual nutrients for fetal utilisation. If spiral artery remodeling does not occur, there is disordered perfusion of blood flow into the intervillar space. This, together with resultant inadequate supply of nutrients and oxygen, reduces the progressive branching of the villus tree as gestation proceeds, reducing the surface area available for exchange, with the possible outcome of fetal growth restriction and stillbirth. A poorly perfused placenta undergoes oxidative stress and produces increased circulation of anti-angiogenic factors. This results in a loss of endothelial hemostasis and can trigger a systemic endothelial disorder, presenting as early onset preeclampsia. Trophoblastic invasion into the decidua and transformation of about 30 to 40 spiral arteries deep in the myometrium is essential for normal fetal growth and development. Thus, the exact clinical presentation of defective trophoblast invasion will depend on the extent of arterial invasion and the number of arteries invaded. So how can we assess if placental invasion has occurred correctly or not in early pregnancy, when there is still time to try and improve the outcomes? The mainstay of maternity care in identifying the at-risk group has been through identification of maternal characteristics associated with abnormal placentation. In other words, taking a good history. Multiple international bodies have produced a list of both high-risk and moderate risk factors that can be used to identify the patient at increased risk of developing preeclampsia. This approach, however, essentially treats each risk factor as a separate screening test with additive detection rate and screen positive rate. Although useful in identifying at-risk women in clinical practice, it's not a sufficient tool for prediction of preeclampsia on its own. Measurement of blood pressure is a routine part of all antenatal clinic appointments. It can also be utilised to screen for abnormal placentation. Mean arterial blood pressure is a standardised measurement reported in multiples of the median. It is ideally collected using a validated automated or semi-automated device. Blood pressure measurements are taken after 5 minutes of rest in both arms simultaneously, and 2 sets of recordings are made at 1-minute intervals. The 4 sets of blood pressure are entered into the risk calculator, and the final mean arterial pressure measurement is automatically calculated. Pragmatically, 2 recordings made at 1-minute intervals in the one arm could also be used. The addition of mean arterial blood pressure to maternal characteristics and medical history almost doubles the detection rate for preeclampsia. Dr. Muller has already covered the benefits of uterine artery Doppler measurement in the 3rd trimester. However, it is also an underutilised resource in the 1st trimester when screening for uteroplacental insufficiency. Uterine artery Doppler PI provides a useful non-invasive method for the assessment of uteroplacental circulation. The Doppler ultrasound assessing the resistance to blood flow in the uterine arteries correlates with both histological studies and clinical severity of preeclampsia. Histological examination of placental bed biopsies of pregnancies affected by preeclampsia has shown that absence of physiological changes of the spiral arteries is found more commonly in cases with a high uterine artery PI. Uterine artery Doppler is measured at the level of the internal os during the first trimester at the time of nuchal translucency scanning. This has been found to be more reproducible than scanning at the iliac crossover and is able to be achieved in a greater proportion of women. Like mean arterial blood pressure, several factors can also affect the values of uterine artery PI. Significant independent contributions are made by gestational age, maternal age, weight, racial origin, history of preeclampsia in the previous pregnancy, and type 1 diabetes. Hence, uterine artery PI values also need to be adjusted for these associated maternal characteristics and gestational age by converting it to multiples of the median. A large meta-analysis of first trimester uterine artery PI measurement for the prediction of preeclampsia included 8 studies for the prediction of early onset preeclampsia involving 41,692 women and 11 studies for the prediction of preeclampsia at any gestation involving 39,179 women. The first trimester abnormal uterine artery PI is defined as greater than the 90th percentile, achieving a detection rate of 48% with an 8% false positive rate for the identification of early onset preeclampsia. The detection rate for predicting late onset PE does reduce to 26% at a 7% false positive rate. Multiple biochemical markers are produced by the placenta with varying levels during pregnancy. PAPA is synthesized by the syncytial trophoblast. As extravillous trophoblast moves deeper, high expression of PAPA occurs. This results in an increase in concentration throughout pregnancy with maximum levels at term. PAPA increases local bioavailability of insulin-like growth factor by cleaving the inhibitors IGF-BP4 and IGF-BP5. Insulin-like growth factor has mitogenic and anti-apoptotic activities, therefore increasing PAPA favours placentation and regulates fetal growth. Preeclampsia has been shown to be associated with a low level of circulating PAPA. PAPA is a well-established biochemical marker in the screenings of trisomy 21, 18 and 13. Significant independent contributions to PAPA are provided by gestational age, maternal weight, height, racial origin, cigarette smoking, diabetes, method of conception, previous pregnancy with or without preeclampsia, and birth weight of the neonate in the previous pregnancy, which is why, putting my MFM hat on here, it's important to fill out the information on the SAMHSA screening form, and also why PAPA is reported in multiples of the median. In euploid pregnancies, a PAPA in multiple of the median at less than the 5th centile is present in 8 to 23% of women with preeclampsia. Therefore, as a single marker, it's not an accurate predictive test for preeclampsia. A recent systematic review and meta-analysis, including 8 studies involving 132,076 pregnant women in the first trimester, demonstrated that the maternal PAPA concentration of less than the 5th centile is associated with the risk of developing preeclampsia with an odds ratio of 1.94. It has a detection rate of 16% at an 8% false positive rate to predict preeclampsia. Placental-like growth factor, or PLGF, is secreted by trophoblastic cells. It binds to VEGF receptor 1, which has been shown to increase during pregnancy. PLGF has both vasculogenic and angiogenic functions. Its angiogenic abilities have been speculated to play a role in normal pregnancy, and changes in the level of PLGF or its inhibitory receptors have been implicated in the development of preeclampsia. As discussed earlier, abnormal placental invasion causes oxidative stress and the generation of reactive oxygen species. This results in the release of inflammatory mediators and anti-angiogenic agents, such as sFlt1. sFlt1 is a soluble receptor of VEGF and PLGF and prevents them from binding to their proper receptor, also resulting in a decreased measurable PLGF level. Like PAPA, several factors affect the value of PLGF in pregnant women, and the result is adjusted and reported as a multiples of the median. Several studies have shown that women who subsequently develop preeclampsia have significantly lower maternal PLGF concentrations in the first trimester than those in normal pregnancies. This biomarker alone has a detection rate of 55% and 33% respectively at a 10% false positive rate for the identification of both early and late onset preeclampsia. A systematic review and meta-analysis demonstrated that PLGF is superior to the other biomarkers for predicting preeclampsia. So should we adopt some or all of these screening methods? The next few slides are very busy, but I wanted to highlight a few key points. Currently, we informally screen utilising maternal risk factors, which should detect about 60% of preterm preeclampsia expected to deliver prior to 37 weeks. Almost all women in South Australia undergo a late first trimester ultrasound, which could easily have uterine artery doppler measurement incorporated into it. With increased utilisation of NIPT instead of a combined first trimester screen, and again, putting my MFM hat on, please don't order a combined screen and NIPT at the same time. The addition of a uterine artery doppler at the time of nuchal or early anatomy scan has an approximately 15% improvement in the detection rate of early onset preterm preeclampsia, compared to approximately 5% from measuring the PAP-A. If we combined all the available screening, we could detect up to 94% of cases of early onset preterm preeclampsia. Also note the last column. As I mentioned earlier, term preeclampsia is not thought to be associated with abnormal placentation, which is why its detection rate is not as good. These findings are similar for small for gestational age, with both preterm and early preterm delivery. Though smaller numbers, there is an improved detection utilising uterine artery Doppler PI measurement compared to PAP-A. The addition of all screening tests almost doubles our detection rate. So now that we have identified the pregnancies at risk of abnormal placentation, is there anything we can do to improve the outcome of the pregnancy? The only current therapy we have good quality evidence for is aspirin. The aspirin trial was a prospective multi-central trial involving 25,797 singleton pregnancies, which was screened for preterm preeclampsia using an algorithm consisting of maternal risk factors, mean arterial blood pressure, uterine artery PI, PAP-A, and PLGF measurement. 10.5% of participants screened high risk for early onset preeclampsia and were offered to participate in a double-blind trial of the effect of aspirin to prevent preterm preeclampsia. 806 were randomised to placebo and 785 to aspirin, 150 milligrams at night time, commencing between 11 and 14 weeks and ceasing at 36 weeks. Amongst the participants randomised to aspirin, 13 were diagnosed with preterm preeclampsia, compared to 35 who took the placebo. This equated to a 62% reduction in the incidence of preterm preeclampsia with aspirin usage. There was no significant difference in the incidence of term preeclampsia between the groups. This was supported by a systematic review and meta-analysis of 45 randomised controlled trials involving 20,909 women randomised between 50 and 150 milligrams of aspirin daily. When aspirin was initiated less than 16 weeks, there was a significant reduction and a dose-response effect for the prevention of preeclampsia, with a relative risk of 0.57, severe preeclampsia with a relative risk of 0.47, and fetal growth restriction with a relative risk of 0.56. Higher dosages of aspirin were associated with greater reduction of all three outcomes. When introduced after 16 weeks, there was a small reduction in preeclampsia with a relative risk of 0.81 without a dosage-related effect, but no significant effect on severe preeclampsia or fetal growth restriction. This confirms the importance of identifying early the patients at risk of abnormal placentation so aspirin can be commenced prior to 16 weeks gestation. Across multiple studies, preeclampsia was consistently reduced with low-dose calcium. This risk reduction was highest in those with a low baseline calcium intake. However, a Cochrane review found this to be low-quality evidence with concerns the treatment effect may be overestimated due to small study effects of publication bias. Further, larger, high-quality trials are required to confirm the impact of calcium supplementation. A randomised trial assessing whether enoxaparin usage reduced the incidence of preeclampsia and small for gestational age in women who had previously affected pregnancy was conducted in 5 tertiary centres across 3 countries, including Australia and New Zealand. 149 participants were included and randomised to standard high-risk care plus 40 milligrams of enoxaparin versus standard high-risk care only. Of note, 97% of the participants also received aspirin. The results showed the addition of enoxaparin had no effect on the rate of preeclampsia or small for gestational age. The STAMP trial was a double-blinded proof-of-principle placebo-controlled randomised trial assessing whether prevastatin treatment for early-onset preeclampsia reduced maternal plasma S-FLT1 levels. 56 women with early-onset preeclampsia were recruited between 24 and 31 plus 6 weeks gestation, of which 27 were randomised to 40 milligrams of prevastatin from randomisation to delivery. There was no significant difference in the mean arterial plasma S-FLT1 level, length of pregnancy, maternal clinical findings, or fetal well-being. Whether there would be an effect if it commenced early in pregnancy, like aspirin, before the process of placentation has been completed has not been studied due to concern of congenital abnormality with early statin use. The STRIDA trial was designed to assess if sildenafil could prolong time till delivery in cases of severe early onset growth restriction. Women were recruited with small for gestational age fetuses with abnormal umbilical artery doppler flow, specifically absent or reversed end diastolic flow from 22 weeks onwards. Participants were randomised to receive sildenafil 25 milligrams 3 times a day or a placebo. The primary outcome was delay of delivery, but changes in fetal assessment were also analysed, in addition to a range of secondary outcomes. No difference was found in the median randomisation to delivery interval between the two groups, and in fact, sildenafil group was associated with deterioration in indices of fetal well-being, specifically the ductus venosus A wave. Secondary outcome analysis showed no benefit with the treatment either. A double-blinded randomised controlled trial was run by the Mercy Group in South Africa to assess if esomeprazole could prolong gestation in women with preterm preeclampsia, diagnosed between 26 and 31 plus 6 weeks gestation. Participants were randomised to 40 milligrams daily esomeprazole or placebo. There were 59 participants in the treatment group and 60 in the control group. There was no significant difference in median time from randomisation to delivery, other maternal and neonatal outcomes, or markers of endothelial dysfunction. The role of effective vitamin C and E supplementation during pregnancy has also been reviewed, with a Cochrane review showing there was no significant difference in the risk of preeclampsia, fetal or neonatal loss, preterm birth, or small for gestational age with supplementation compared to placebo. The Mercy Group had performed a functional in vitro and ex vivo experiments using primary human tissues to examine the effects of metformin on S-FLT1 and soluble endoglin secretion from placental endothelial cells and placental villus explants. They found that metformin reduced S-FLT and soluble endoglin secretion, possibly by inhibiting the mitochondrial electron transport chain, which is increased in preterm preeclampsia patients. Metformin also reduced endothelial dysfunction, enhanced vasodilation in mental arteries, and induced angiogenesis, indicating it has the potential to prevent or treat preeclampsia. They've been recruiting for a clinical trial over the last few years to assess if this effect translates into practice, and the prevention of preeclampsia using metformin randomised controlled trial, or PREMET, has been planned by a group out of Qatar and is scheduled to commence recruitment this month. So now we know a bit about how abnormal placentation can cause issues in pregnancy, identified the women at risk, and found an effective intervention. How can we apply it to our patients? There are approximately 20,000 births per year in SA, of which we'd expect approximately 660 cases of preeclampsia, and of those, about 165 will deliver prior to 37 weeks. If we screened all our patients for those classed as high risk, advise them to start aspirin at 150 milligrams noctate prior to 16 weeks of gestation, which from my quick visit to the chemist would cost about $5 per woman. If we use maternal risk factors alone, we would improve the outcomes for 60 women and their babies with a number needed to treat of 64. If we incorporate a mean arterial blood pressure and uterine artery PI into our screening, we would improve the outcomes for 79 women and their babies with a number needed to treat of 43. If we adopted the full screening regime, including biomarkers, we would improve the outcomes for 82 women and their babies with a number needed to treat of 36. So in summary, abnormal placentation is associated with major pregnancy complications, including early onset preeclampsia and fetal growth restriction. Effective screening in early pregnancy is available with a simple treatment option in the form of aspirin commenced prior to 16 weeks. Therefore, we should ensure our patients are being reviewed and assessed for abnormal placentation risk, just like we do for aneuploidy screening, in a timely manner at the end of the first trimester. This will allow an opportunity to commence aspirin and hopefully improve the disease burden and conditions associated with abnormal placentation cause. Thank you.